First of Representative Ryer's bills that we're going to take up is House File 1296. And the motion, Representative Ryer, would be to have House File 1296 be laid over for possible inclusion. Is that your motion?
Thank you, Madam Chair. That is my motion.
All right. And you have an A1 amendment. Did you want to move that now?
Yes, I'd like to move it and just have the bill in the shape to present it.
All right. So let's adopt the A1, and then Representative Ryer will explain it as amended. So all in favor of adoption of the A1, I guess it's the A1-2, is that correct?
That's correct, Madam Chair.
All right. The A1-2 amendment, please say aye.
Aye.
Aye. Any opposed? The motion prevails. The amendment is adopted. So to your bill as amended.
Thank you, Madam Chair. Thank you, members. As you'll have seen from the agenda, I have 3 bills up today related to dental care. And I just want to preface that by saying it's all looking at how do we find ways to provide the necessary care to people in a more innovative and cost-effective way that addresses needs that we haven't addressed so far. And with that perspective, I'll be coming at it from 3 different directions. So appreciate your consideration in that context. House File 1196.
Oh, it's 1296.
1296, oh, a typo in my own notes. House File 1296 establishes a funding source for ongoing in Minnesota statewide critical access dental or CAD infrastructure. As you'll have been hearing, and you'll hear more from the testifiers, these are the providers who specialize in providing care and make a mission out of providing care for people who are on public programs and who may have more complex dental needs. It is a set of organizations that have faced many challenges in being able to have a financial bottom line that works for them, and also have the flexibility to implement programs that they know will make a difference for their patients. So this bill proposes that we establish a grant and forgivable loan program for dental clinic infrastructure investments, both physical plant and equipment, for CAD providers. This would help the high-volume MA providers maintain and expand their capacity. And this bill is also amended to include a workforce component where staff, especially in these CAD providers, many of whom are rural or in the urban areas serving challenging populations, would be able to develop staff, and that higher education institutions would be able to have innovative programs for that. And you'll hear more from one of the testifiers. $20 million is appropriated in fiscal year 2024 for the infrastructure portion, $5 million for the workforce piece. This is a one-time appropriation. It would be available until June 30th, 2026. As a housekeeping note, I'd like to point out that the amendment has a typo on line 2.25. That should be 20 million instead of 25, and we'll correct that as we work through any additional clarifying changes after this is laid over. With that, Madam Chair, I'd now like to ask my testifiers to speak further to the bill.
All right. Thank you very much, Representative Ryer. So please go ahead and introduce yourself and go ahead with your testimony.
Good morning, Madam Chair and members of the committee. My name is Kate Tunjum, and I'm the Chief Operating Officer at Southern Heights Dental Group in Faribault, Minnesota. It is my pleasure to be here in front of you today in support of these bills. Specifically, I will speak to House File 1296. So Southern Heights Dental is located in Faribault, Minnesota, but it's always been our mission to serve the underserved population. We've been in business for over 40 years. It was my dental office as a child, and I moved back and started working with them almost 12 years ago, and our mission continues to be to serve our community. Our community has been outreached to rural areas all around Faribault, southern Minnesota, western Minnesota, down to the Worthington border and up to Dakota County, serving those both privately insured and fee-for-service patients, along with a heavy emphasis specifically since 2016, on Medicaid and Minnesota Care programs. So to give an idea, we are one private group practice, brick and mortar, but we have 7 dentists, 3 dental therapists, 18 dental hygienists, and 32 operatories. Last year, we saw 32,000 patient visits, and over 52% were of the Medicaid and Minnesota Care programs. And so we're heavily invested in continuing to do everything that we can do to serve this population, children, very diverse population of Somalian culture, Hispanic. So we've brought in the infrastructure of people. We've hired interpreters, and we've hired dental therapists to do outreach. And now we'd like to be able to and have the ability, if House File 1296 does come into a bill, that we're able to apply for forgivable loan or a grant, which is unique for a private practice to have the ability to do that. And what we would specifically try to do is carve this money out to add additional physical exam space. We've hired a 3rd dental therapist. They see our most vulnerable population, and we'd have more room to continue to see all of these children and adults that end up coming to our office, because we are one of few that take that capacity of patients in need in southern Minnesota. And so this would be extremely helpful, and I know that it would give back and make an impact to the state.
All right. Thank you very much for your testimony.
You're welcome.
We have some other testifiers. Eric Colon. Welcome to the committee. Please just state your name and go ahead with your testimony.
Good morning, Madam Chair and committee members. I'm Eric Colon, a duly licensed dental therapist and registered dental hygienist employed by Children's Dental Services. Today, I'm here to testify with my wholehearted support for House File 1296. Children's Dental Services is a nonprofit dental clinic serving Minnesota's most vulnerable children since 1919. With a team of 100 incredibly skilled, multicultural staff members residing in 23 different counties, and we treat over 38,000 predominantly low-income children, pregnant women, and family members of all ages at brick-and-mortar clinics and portable sites across 56 Minnesota counties. What we do is only possible with grants and additional support from our heavily used equipment and facilities. Over the past year, I personally have seen over 2,000 patients using portable equipment that I have traveled in utility vans across Minnesota in Aiken, Carlton, Itasca, Cochise, Pine, St. Louis counties to the north, Becker, Clay, Sherburne, Stern counties in the central, and across 9 counties in the metro area, as well as across Jackson, Nobles, Rock, and Wanwan counties in the southwest. And that's just me. When I provide care at one of our brick and mortar clinics in northeast Minneapolis, I have patients lined up in the waiting room and at the ready in multiple rooms as where I move to and fro. In Duluth, we have over 7,000 patients on record and are renovating a building to open up a brick and mortar dental hub. I am never idle, and neither are any of my dental chairs or facilities. While a team of our trusted colleagues continually maintain our equipment and facilities, reaching their useful lifespan up to 100% beyond what is expected, we cannot keep pace with the current demand or expect to keep up with the future needs without critical access dental provider infrastructure funding that you are considering today. I come from a rural working class family of color that struggled to access dental and healthcare resources we needed. I am here before you today because Minnesota state grant funding contributed to the cost of my education to become a registered dental hygienist and dental therapist. Over a decade ago, Minnesota state legislators passed pioneering dental therapy legislation to create my profession. I am proud to stand here before you to serve my community and give back to the state that invested in me. I can only be here because of the leadership and support of Minnesota legislators before you. So today, I urge you to support the critical access dental infrastructure funding so that I may continue to serve diverse communities of the state for futures to come. Thank you.
Thank you for your testimony. And next we have Dr. Helgeson. Welcome to the committee.
Thank you so much. Madam Chair and members of the committee, I'm Dr. Michael Helgeson, the CEO of Apple Tree Dental. a nonprofit which is one of Minnesota's largest critical access dental providers. In the last 2 years, our team has served tens of thousands of patients from literally all 87 counties in Minnesota, providing almost 200,000 dental visits to our most vulnerable citizens. As a proud Minnesota-based provider, Appletree's focus is on Minnesotans in need. We provide comprehensive and special care services to our children, adults, and our seniors. To meet their needs, we must collaborate. Appletree operates programs within both rural and urban hospitals, and we bring care to our elders at nursing facilities and to our children at Head Start centers and schools. I want to thank Representatives Liebling and Ryer and all of your colleagues for your strong commitment to the many facets of our state's dental access crisis, including one of the aspects of this bill, which is workforce shortages. Today, Minnesota healthcare employers, including critical access dental providers, face severe workforce shortages. Sadly, there are thousands of patients on our waiting lists while their conditions worsen. In just 1 month, we had over 9,000 patients on Appletree's waiting lists at our centers around the state, which is not acceptable. Your support for this bill will help open the oral health workforce pipeline. At the beginning of the pipeline, we're reaching out to high schools to recruit more diverse team members. To expand the number of oral health graduates, more faculty are needed so enrollment can be increased. To retain current staff members, we need to invest in training so they can be at the top of their productivity. And the Great Resignation included dental team members. So to bring them back into the workforce, we're developing some new flexible employment models that would allow them to come back in very flexible ways, including working from home to do teledentistry, which is another way to bring back all these folks that are on the sidelines right now. Finally, we're teaming up with physicians, nurses, community health workers, and many others to expand the interprofessional care workforce. So critical access dental providers are proud to serve Minnesotans most vulnerable, and this legislation will help open the workforce pipeline so we can bridge the oral health gap for all Minnesotans. Thank you so much.
All right, thank you, Dr. Helgeson. And before I go to Representative Backer, could you just, I've heard this telehealth dentistry. It's a little counterintuitive. Could you just give us a moment on what that looks like?
Sure, I will reflect back more than 20 years when we first started. We were the first in the nation here in Minnesota to do teledentistry. Started for Head Start kids. And so the example there is you would have a hygienist at a Head Start center with a high-resolution intraoral camera, gadget where you can get really clear pictures of all the teeth, digital x-rays, all could be, and charting could all be uploaded at the Head Start center. And a dentist, maybe the next day, can go through all of those images, charting, x-rays, and develop a treatment plan for that child. And what that does is it saves an entire visit. The very first time that child comes in, travels, their family incurs all those expenses, they're actually getting the work done instead of coming in just to have an evaluation done. During the pandemic, this was critical. Appletree is the largest provider of services to nursing homes, and as you know, during the pandemic, nursing homes were like Fort Knox, but people were still having incredible dental problems because they weren't having the staffing and help with their daily care. So using teledentistry, live teledentistry, we're able to link with a phone, a tablet, a computer, and connect to a nurse in a room with an elder and look in their mouth and see what's going on and figure out if we can treat them medically at the nursing home or if they have to make a trip during a pandemic with staff and medical transportation and everything else. And if they're going to do that, we can know what they need. So when they do come to the clinic, instead of just being evaluated and going back and coming again, we can actually do the care they need right at that visit. So those are just the tip of the iceberg, but there are many other applications like that.
Thank you.
And frankly, for recent retirees, boomers, which I guess I'm obviously one of them, there are a lot of them out there that are licensed and aren't active right now. They pulled out. But with these new models, they could come back in to the extent and when they want to. And I think there's we've done a study of that, and we think there's a lot of FTE equivalents out there that could be brought back in.
Great, thank you, Dr. Helgeson. Representative Backer.
Yeah, thank you, Madam Chair. A couple questions here. First of all, how many critical access providers right now roughly are in Minnesota?
I think Jogo might have.
Mr. Hayes?
Madam Chair, Representative Backer, if my memory serves, it's 176, but they're by clinic. And so each clinic, for example, Apple Tree has numerous clinics, locations, sizes are different, et cetera.
Okay. Madam Chair?
Representative Backer, do you want it to stay?
Yes, probably. Yeah, unless someone wants to call a different friend. How many of these providers do you believe would benefit from this bill?
Mr. Hayes, is that for you?
I'm not sure that's, I
Okay.
mean, I might defer that
All
to
right,
Representative
maybe
Breyer.
that's for the author. Representative Breyer.
Thank you, Madam Chair. Thank you, Representative Backer. This would be available to any of them, and I would say that from what I heard over the course of the work I've been doing for the last few years on dental issues, there's a strong appetite for the ability to invest in their organizations in ways that they haven't been able to invest in their capacity and their tools. So I would expect a relatively high interest that I can't quantify in terms of percents, but this is not a niche type of thing. It's not tailored to be so prescriptive that it would be a hard thing for providers. And in fact, the goal of it is that we want to make it more appealing and easier for providers to care for more patients. That's why we included, for example, for-profit organizations that treat Medicaid and Minnesota Care patients, because it's incentive to be able to do this important work.
One final.
Representative Backer?
Thank you, Madam Chair, and I appreciate that. Another question, and maybe this is MDH, answer yourself there, Representative. What do you think would be based on what you've seen in the past and what this would allocate, what the average award may be for these providers? Are we talking about tens of thousands of dollars, or, you've done a lot of research into this. What's your intention, and what would past history tell us? Thank you.
Representative Breyer.
Thank you, Madam Chair. Thank you, Representative Backer. This is not designed to be full scale. We need to build a whole new dental center, as you can see from the amount. It wouldn't go very far if it were, for example, the new dentist clinic that was built out in Buffalo went through the standard bonding process. This is designed to be more flexible. I would expect them to be not in the millions of dollars, but I have not seen a needs assessment that would tell me, is it $5,000, is it $50,000?
No further questions.
Okay. Representative New Brindley.
Thank you, Madam Chair. And thank you, Representative Breyer. I really appreciate the intent of this bill. I'm a little concerned about how the numbers play out, and I'm a little concerned about some of the workforce stuff. And I'll tell you why. Number one, I'm a little concerned. I mean, really, if there are 176 critical access providers across the state, and we're offering $20 million, that's $113,000 per provider. That's a pretty significant boon when we're just talking about the infrastructure piece of this. And then on the flip side, as we know, as we hear in every single committee from every single sector of the economy, workforce is a huge problem. And this is another one of those areas of workforce that we can't turn it over to robots. We need people. We need people doing these jobs. And so as I look at the workforce section, I guess I would ask what your intention is. Is it to support the critical access dental providers, or is it to put more money into education for bringing these folks in? I'm trying to figure out how this will interact in reality on this workforce provision. Frankly, I'm concerned about institutions of higher education. it's $5 million, which is not a huge amount of money, but that could very easily be gobbled up by the University of Minnesota, who has a dental program. And I'm not sure that that's going to solve our problem of getting more dental assistants, dental hygienists, folks like that into this pipeline of workforce. And so I'm a little bit concerned that this language and the way this is going to play out in practice is maybe not going to solve the problem that we really want to solve. Does that make sense? So I'm just wondering how you foresee that interacting and what your intention really is with the workforce funding here.
Representative Ryer. And Dr. Helgeson, feel free to sit down. It's fine. And then I'm sure we'll have some questions for you as well.
Thank you, Madam Chair. Thank you, Representative New Brindley. I think that's a really excellent question around the workforce, and I am going to ask Dr. Helgeson to comment as well, but first I will just say that to me there's a both and aspect to it, that I think there's a lot of innovative and important work that can be done outside of the major institutes of higher ed, and that we need to be tapping into that. And we need to be having a way for people in the provider community to connect with the higher education resources, maybe in different ways in terms of just, in the workforce itself. I'm not even going to speculate on what they are because I'm neither a dentist nor an educator. But to me, it's opening up new possibilities. I think there's a lot of opportunity, too, with our community and two-year college and our technical institutes that I would like to see explored. And so it would be more that and not, say, an endowment to any one institution. Dr. Helgeson, would you add anything?
Dr. Helgeson.
Thank you, Madam Chair and members of the committee. Just wanted to make a couple of quick sort of framing comments that I think would be helpful. And then maybe before that, I am a member of the Critical Access Providers Get Together, and I would say 100% are getting calls and have waiting lists and would take advantage of these grants, and that they could be of all sizes, from very small to, adding a couple of treatment rooms. So I think the range would be big. I think the 175 figure on the number of critical access providers is very misleading, and I don't mean to say that in any pejorative way. Jogo did mention that one clinic of Apple Tree could be a provider and could have dozens of clinicians in it. We did a workforce analysis that showed that there are about 535 full-time equivalent dentists working in the Medicaid space. And of them, more than 2/3 are critical access providers. So about 2/3 of all the dental care being delivered is by this group of 175 billing points. But it really is the major source of dental care around the state. And then I think on the sort of the workforce issue, all of these things are interconnected. You need to have extra chairs if you're going to employ more people, and if you're going to have more, patients flowing through. And then you have to have more people to work in those chairs, and that's where all of these innovations to really bring more people either back into the profession, in the case of boomers that are on the sidelines right now, and really dentists, hygienists, assistants that are in that age group are licensed, and they're not active. Many of them pulled out during the pandemic, and they're out there. So if we can give them creative new ideas how to get back in, we'll be able to get them back in. So I hope I answered your questions.
Representative Nadeau? I'm sorry, New Brindley.
Thank you, Madam Chair. Yeah, thank you for that. And frankly, this idea of getting, older folks who have left, bringing those back in, that does not allay my fear when it comes to institutions of higher education. And I wonder, perhaps as this moves forward, I wonder if it would be worth exploring a little bit more specifically where those dollars would be most useful. I mean, like I said, I mean, I bring up the University of Minnesota, they've got a dental school there. Is that where we want that funding to go? Or frankly, Representative Ryer, you know, you brought up working with MINSCU, our community colleges, our technical colleges, where we would likely be producing more of the dental assistants and hygienists and folks like that who we desperately need in the field. And I don't know if maybe there is better data on what's the bottleneck. What do we need the most? Do we need hygienists? Do we need assistants? What? And I'm sure the answer is we need everything, but where can we get the biggest bang for our buck with the dollars that we're appropriating as a legislature? The $5 million probably won't make a huge difference for the University of Minnesota, but could make a huge difference in helping folks at the technical college level or a community college getting a 2-year degree. And so I wonder if it would be worth taking just a little bit of time to tighten that up and figure out more specifically what we want to target with this. Because I would just be concerned that with the way it's written, that it probably is not your intention, that it would, you know, just go to the University of Minnesota or whatever that may be, but it could happen. And so I wonder if we would want to tighten that up just a little bit. The other thing that I would always suggest, and I hope that you would consider on program oversight, the language says the commissioner may require and collect from grant recipients any information needed to evaluate the program. I would just suggest that the commissioner will require and collect grant information. It's just always a good idea. We should know what's happening with these dollars. We should know how successful we are. We should know how many new dental hygienists or dental assistants we've been able to produce with this money, and I hope you'd consider that kind of a change. Thank you, Madam Chair.
All right, thank you for the good discussion there. And I just would note, too, that the Department of Health has in its budget a large workforce proposal. And I don't know right now if what overlap there may be, but I just want to put that out there. We haven't heard that yet, but thank you for the good discussion on it. So I have Representatives Nadeau, Carroll, Murphy, and Quam, and then I think we'll try to move to the next bill. So Representative Nadeau.
Thank you, Madam Chair. And I'm not going to, waiting for others to speak, sometimes you get a lot of your questions asked. But Representative Backer started with getting the number of clinics. What percent of dental clinics across the state are critical access? Is it significant? Is it 10%? Is it 20%? Is it a small percentage? Just
Should we get Mr. Hayes down here again? Dr. Helgeson, do you
Madam Chair,
know?
it looks like the fingers are pointing at me. I think there are roughly 4,000 dentists licensed in Minnesota, and the full-time equivalent, the people that are in the critical access provider programs, maybe 500. So that would be the percent.
Sure.
Even though their percent is small, they're providing, as I said, more than 2/3 of all the care. So most of the general dentists, if they participate as maybe 5% of their practice or less. So most of the
I
access is
appreciate
coming
that.
Yeah,
from that.
Thank you.
Representative Nadeau.
And so my point that I'm trying to make is that there's and albeit the small number of providers are providing an enormous amount of care, and that's why they're deemed critical access, which is fantastic. $25 million and another $5 million is not going to increase your capacity in a significant level in order to reach those needs. And I'm old enough to remember when then Representative, now Mayor Norton, carried the oral health practitioner bill in this body a number of years ago, and that was actually going to increase access. That was going to provide, all the dental health services across the state. And I'm not being disrespectful. It was well intentioned. And it was hard work, and it was good work that was done, but we know it didn't meet that need. So the point that I'm trying to bring up, and I have a question later in just a second on grants versus forgivable loans and this particular thing. But it seems to me that we're focusing on a limited resource, albeit important, and maybe this is the best way to try to increase their access as much as possible, when we should be focusing on how do we increase access across the board? How do we get more dentists? How do we get the other 3,500 licensed dentists in Minnesota to participate in a program that we know is necessary and needed? How do we do that? And I don't think this does that.
So I'm going to let Representative Ryer respond, but I just would say that we are hearing a number of bills today, and one bill doesn't do everything, but Representative Ryer.
Thank you, Madam Chair. Thank you, Representative Nadeau. I was going to say one bill doesn't do everything. And it's true. This is a piece. This is a piece that gives a resource to some providers who may not otherwise be able to expand their capacity. And you, as I noted earlier, it isn't restricted to any particular segment. It's open to any type of provider, the 3,500, if they are providing care to that segment of the population. The rate increase that went through last biennium was designed to help bring in more people. When I think about all of these dental bills and how to address the needs, I am thinking about how to look out for those who are already doing 2/3 of the coverage, and I'm really looking at how do we expand the base of dentists who are able and willing to provide those services. So we can have offline conversations about that too, because to me, the more we can do to expand the universe in a meaningful way, the better off we'll all be.
Representative Nadeau?
Yes, just a quick follow-up. I appreciate that. I'm not going to, and I will talk to you offline on that more philosophical component. If we get down to the bill itself on line 1.18 in the original bill, let me just make sure. It's where it's subdivision 2, grant and loan program established, 1.19. Nope. Commissioner will make grants and forgivable loans, wherever that language is in the amended language. And my question is, is it not, is it
I
gone?
think it is 1.18, Representative Nadeau.
1.18, 1.19?
Yep.
Okay, thank you. So can you describe to me the difference and how you anticipate the commissioner will differentiate between a grant and a forgivable loan?
Representative Ryer.
Thank you, Madam Chair. Thank you, Representative Nadeau. I can't speak for the commissioner, of course, but I would see that as a tool for determining where we want to have more, a different level of review or expectations. I would imagine that's how those differentiations are typically made.
Representative Nadeau?
Thank you. And I would recommend just get rid of forgivable loans. I mean, if we're going to grant these dollars out, you know, I mean, if it's, I would just get rid of them, if that's the case.
Representative Ryer? Or Representative Helgeson?
Well, thank
sorry.
you. I'm not a representative.
Dr. Helgeson.
I am a dentist.
You're representing, we all represent something, right?
Well, Madam
Yeah.
Chair, and thank you for that question. One of the considerations that the critical access providers had is that the ones that are structured as a for-profit, and you heard earlier from one of the stellar for-profit practices in rural Minnesota, they technically can't get a grant because they're not a C3. But they could have a forgivable loan where, as a for-profit, if they agree to do a certain expansion and serve more patients and yada, yada, at the time they've delivered that, their loan would be forgiven. So that was one of the nuances for that provision.
All right. I
appreciate that. Thank you.
All right, thank you very much. So we have Representative Carroll, followed by Murphy and Quam. Representative Carroll. Oh, he stepped out. Okay, we'll go to Representative Murphy.
Thank you, Madam Chair. Thank you, Representative Ryer. Representative Nadeau took most of my thunder, but I do have one more question based on that. And it comes down to, one bill can't do everything, but one bill could do more. And just from a business look at this, you want to be able to give everybody a grant or, a loan that they don't have to pay back. But a lot of people that are in business for profit, they would benefit also from just a loan without any interest. And so a low interest or no interest loan, but you talk about some of the other parameters that would help, like your school, like dental school, maybe we would have more money to deal with that. Maybe this program would go a little further if we did that. And I think there'd be a lot more people that would come into play if you had that as an option. So that would be something to consider. Any thoughts on that?
Representative Reier?
Thank you, Madam Chair. Thank you, Representative Murphy. It's certainly worth considering. To me, this is a fairly targeted program in order to broaden the base of providers. So I would just want to think through and talk through the details of that, but love having new ideas for dental service.
Great. Yeah, I just
All right,
kind of go again, one bill can't do everything, but we can always do more. And this would definitely widen out the scope of the bill a lot.
Yeah,
Thank you.
Thank you. Representative Quam?
Thank you, Madam Chair. And with the discussion Representative New Brindley had with the author, I think it'd be nice to explore a PSAO combination with VOTEC and community colleges to sort of springboard dental assistant and dental hygienists. And with that, pair up a program that allows dental assistants and dental hygienists. You're there in a dentist's office and have sort of either a working or internship type program for people pursuing a degree in dentistry. And that way, it helps them to be familiar and sort of bridges into it. So a creative way of sort of filling up that stream. At the U, I was in a, they called it a grad house because we had a mix, and there was a dental student. And I noticed that he had periods of extreme heavy load, and then he had, less pressure. And if we can sort of do a cooperative between the dentists and the school, that might expand the pool of people that can afford to go into it, and also allow them to be better prepared as they come out as a dentist, because then they'll have appreciation for all the team members in the office. So I'd hope that, author and others would look at a creative way, because too often these bills we're going to do this, and it's a general bucket without a lot of definition. I'd like to see some definition come out in these bills. Thank you, Madam Chair.
All right, thank you, Representative Quam. And so this bill is, I don't see Representative Carroll is back, so we're going to then, you have a final word on this, Representative Reier? Why don't we do that quickly, and then we'll move on.
Thank you, Madam Chair. Thank you, everyone. I've really appreciated the ideas, the thoughts, the input on this. And I have to especially acknowledge Representative Quam, who answered Representative New Brindley's question about whether I had concrete ideas on how this might work. That's the kind of thing that would be my intent. I am, and I want to be able to leave room for the brilliance of the community to say, here's how we can make it work in our need and not be too prescriptive. And so we'll find a balance on that, but I'm really excited about the ideas and the potential, and I thank you all for your engagement.
Yeah, thank you. And with that, House File 1296 as amended is laid over for possible inclusion.